So my name is Andrew Pinto. I'm a family physician, a public health specialist, and scientist based in Toronto. And I'm really pleased to be joined by Jaky Kueper today for this first webinar in our series of 6 on AI in family medicine. And we're going to be covering an introduction to AI and applications in primary care. Just to begin with our disclosures, so I have no specific connections with for-profit or industry, but want to, just in the merit of transparency, really acknowledge where we get research grant funding from, which is from government and foundations. Also, my salary support is from universities and from foundations. And one note at the bottom that I have been serving as an unpaid advisor to a startup company. And then for Jaky, this is her disclosures where she's been receiving support for her time and research as well. We've received in-kind support from the College of Family Physicians, which kindly waived our registration fee for CME accreditation. And the Upstream Lab has been contributing staff time and coordination for this work. And in terms of mitigating biases, we just want to acknowledge our scientific planning committee, which is made up of the folks listed here, who have done a tremendous job keeping us on track and also to ensure issues around bias are addressed, including identifying speakers, helping with the objectives, and also informing the principles that guide this series. And I really want to highlight Jane Cooney and Joanna McFadden, who are 2 of our patient partners who have done tremendous work on this planning these series. So as is traditional in Canada, we want to just begin with acknowledging the land on which we are meeting and living. So I'm based in Toronto, which for many, many centuries has been the traditional land of the Huron-Wendat, the Senecas, and most recently the Mississaugas of the New Credit. And Jaky is now in Montreal.
Yes, I'm joining you from Montreal, or Dojage, which historically has been a meeting ground for many First Nations. And I would specifically like to acknowledge the Guanagahaga, the Huron-Wendat, Abenaki, and Anishinaabe.
And we are very grateful for the opportunity to live and work on this land, and also acknowledge that these lands continue to be the home of many Indigenous people from across Turtle Island. One of the things when we do land acknowledgements is also try to leave people with something tangible that can enforce their learning or for them to take action on. And we want to point out this new book that was just published very recently on Indigenous data, sovereignty, and policy. And it's actually an open access book. And there's a wonderful chapter by colleagues, Robin Rowe and others on Canada and how these principles can inform our work here. So the objectives for this session are to define AI in related terms, understand how it's being applied and in primary care, and also the overall objective of this series is really to help build everyone's confidence in appraising these types of tools that are emerging. We also want people to understand how you can be involved in shaping AI as it gets integrated into primary care. So AI is a very broad term. It was first introduced in 1956 at a conference that was organized at that time. It can be simply defined as a machine behaving in ways that would be called intelligent if it was seen by a human. And it is a very broad study, including computer scientists, but also many, many others. And I would say, as it gets applied in healthcare, also members of the health care team. Now, AI and health has become a really big focus for us. These are just 3 reports from the Canadian Medical Association, the College of Family Physicians, and the Royal College on AI and health. And you can see there's been a real focus on it. Why now? So really, why has AI become something that is so important and something that is really really kind of challenging us and thinking about really how is this going to influence our work? And I actually want to pause here and do a poll of everyone to ask you a question about, do you think overall AI, just based on what you know right now, is going to improve the practice of family medicine or not. So let's see what people think. We'll give people a moment to fill this out. You can see that the audience here is pretty overwhelmingly supportive of the idea, but also there's this big group, about 20% of people who are unsure, which is, I think, great as well to see. So really, why now? What's been going on now with AI? One of the things that's really propelling this field is the availability of data, and that's something you'll hear throughout these series. We're in a time of an enormous amount of new data that is now available and also can be linked between sources. And these are just some examples, from genetic data to our activities, to what medications we're taking, to also information about our context as well. And just to note that there is a difference between AI and big data. Sometimes we conflate these terms. AI, as we'll explore, is really about making sense of data and using some specific techniques that mimic the way humans think. And whereas big data is really about using these vast amounts of data. And we've given a couple of examples of what this could look like in either area. There is also areas which intersect, where you'll see that big data is actually necessary to do some of the work that we are doing, where we're applying AI techniques. So AI is an area that has many different subfields within it, which overlap. So although we'll be covering a few distinct methods, one thing to note is that many of these intersect with one another. And these are some of the ones that we're going to talk about today. So another key take home from today is that AI is already here. It's just not evenly distributed across the health sector. So many of the things we're talking about are already in practice. And of course, there's much more that remains to be done. So to start with one example of AI, which is an older example, are expert systems. So these are systems that exist that bring together the knowledge base, the evidence that has accumulated, that's often published in the medical literature, and bringing it to bear on questions that are emerging within clinical care. And then a user is interfacing with this system, posing questions or queries and receiving advice from it. And you can imagine that also a system like this could get better over time and actually seek to better refine its answers and better hone in on what type of evidence is really helpful. One example that goes back to 2004 is this example in pediatric clinics in the US, which use a constant feedback of looking at the data, posing questions to patients, and it being involved in informing clinical decisions. Another area is natural language processing. So some of you may have heard of this term before, but this is where a computer is trained to make sense of written language, of text data. And this figure goes through the steps that happen, where it begins with first identifying the boundaries of a sentence, breaking it into pieces, and then tagging it with different meanings, and then actually being able to identify an entity. In this case, this sentence saying that this is speaking about obesity, coronary artery disease, and also it's talking about a family history as well. One example of the use of this is a new project that we'll actually hear about in webinar 3, which is, imagine applying natural language processing to the audio of our encounters, to our visits with our patients, and making sense of this in a way that actually generates a note that is tailored to the way that you or I write our notes, as well as creating a handout. So we'll hear more about this in webinar 3. Another area is machine learning. So this is a broad array of methods. There are many different types within this, where a program learns from experience that it has acquired from engaging in different tasks, and where its performance gets better as it learns, as it looks at how it's performed. So ultimately, machine learning is about discovering statistical patterns in data. So making a prediction or identifying a relationship. And the beginning point is always a set of training examples. And this machine learning can be divided into two broad areas: supervised learning, which takes data that has been labeled by a human and actually builds a model that predicts an outcome from these labels, versus unsupervised learning, which we're going to hear more about, which takes unlabeled examples, so no one has decided what these mean, and it actually looks at similar features and starts to label the examples itself and trains itself by looking at how accurate was it at making a sense of this. So essentially, it goes through steps of collecting and annotating the data, then training the model, filtering or aggregating or generating some desired content, such as a score or a label, and then people see output. Now, one of the things that's propelled this whole field is that starting about 15 years ago, there were advances in the technical approaches and an increase in the data, as we talked about. And it's led to a type of machine learning, which is called deep learning. David Naylor, who's the former dean and president of U of T, had this article where he talked about the potential of deep learning for the health system. So deep learning is highly adaptable and helps integrate data from many different sources. It has the capacity to inform discovery in health research and develop new hypotheses. And also it can be used to streamline work of health professionals as well and learn over time what works better. One of the kind of well-known books in this area has been this book by Eric Topol, who's a physician in the US, who has coined this term and moved to this area of deep medicine, so the application of deep learning to medicine. And this is, he paints a fairly optimistic view of AI, that it could provide composite panoramic views of people's medical data, help with decision-making, avoid errors, and help reduce unnecessary tests, and also provide recommendations for treatment. Another area, so moving away from machine learning and just to move through these briefly, computer vision. This is a field of AI that involves training programs to interpret, make sense of the visual world, of photos, of videos. And it uses deep learning to train itself to identify and classify objects. And the part of what's led to a huge application of this is the availability of cameras, computing power, and new methods, and particularly artificial neural networks. One clinical example of this, which some may have heard of, is using a phone to capture an image of a skin lesion and make a diagnosis of whether or not a lesion is a melanoma or not. And in a study that's been widely circulated in Nature, this program actually performed as well as dermatologists at helping differentiate. Another example of the application of computer vision is around radiological images, where an image is broken down into small pieces and then sense is made of it, also the connections between those pieces. And one clinical example of this that's happening right now in the hospital where I'm connected to is actually making sense of images of head CT images to quickly say whether or not there's a concern of a bleed, and actually help it rise on the pile of films that a radiologist is then looking at. So it's certainly keeping a human in the loop, but it's just helping bring some of those images and higher on the pile. Another example of machine learning in action is around cancer treatment. This is some work being done at Princess Margaret Hospital and the UHN here in Toronto, using machine learning to much more quickly develop cancer treatment plans, taking what used to take hours into a few minutes in terms of bringing together data on the type of cancer, where it's located, and helping come up with treatments. So I'm going to turn it now over to Jaky to continue this conversation, talking about how AI is getting applied in primary care.
Great, thank you so much for that introduction. So this slide is just showing, providing an overview of different types of techniques. And there's sort of a bit of a transition that's happening in terms of the value and the types of information we can gain from using artificial intelligence and the difficulty of actually doing those tasks and importantly doing them well. So kind of at the bottom, the starting part is more descriptive, so using data that exists and figuring out what has happened. Then moving more to, well, can we figure out sort of why these different things happened? And the next step is thinking about, well, okay, so now we know what happened. Can we predict what's going to happen in the future? And then sort of the most difficult task, potentially one of the most valuable, is thinking about, can we actually now figure out how we can change what's going to happen in the future? So we can go to the next slide. So I'm going to talk to you first about a study that I did with some colleagues listed here that was really motivated by it seemed that there was all this increasing attention towards artificial intelligence and in the medical field, but anecdotally, a lot of it seemed to be happening in tertiary care settings. So we really wanted to know what's happening specifically for primary care. And so we set out to figure out first, what's all the research that's out there that could be relevant to AI in primary care. And we found 405 articles. And so I'm going to just walk through some of the main findings. So first, thinking about where is this research coming from? You know, where are the data? Where are these things being applied? And so the bars just are the counts. So they all adding up all the purple would equal 405. And you can see that in terms of sheer volume, the United States is producing the most. And the numbers at the end of the bars are per capita rates though. So that's sort of adjusting for population size. You can see amongst the countries or the locations that are sort of producing a fair bit of research, the Netherlands is really, really high there. So next slide. I also want to mention there's not a lot of low and middle income country representation there, which is important to note as well. Okay. So the next thing we looked at is, what are these studies actually saying they want to support within primary care? You know, what would be the relevance for example, for you as a clinician and for other people in your clinics? And the top four are listed here, and I'm going to go through an example of each. And so the first one is for supporting diagnostic decisions. So you can imagine a patient comes in with some sort of concerns or complaints, or maybe you've run some tests, and there may be some uncertainty in terms of what the actual diagnosis is and whether or not you maybe want to refer them to a specialist or what might be the next step. And so an example of a tool that was developed to sort of support this is one where you would put a microphone up to someone's heart. It would record the sound. It would extract sort of the frequencies and turn that into actually like a picture. And then they train one of those neural net or supervised machine learning model on that to try and predict whether or not someone's, for example, heart murmur is abnormal or not. So should you be concerned? And so that may be an extra piece of information to support what you're getting or what you're suspecting. So next. So another similar one is thinking about treatment. So here you might have a patient who you've just diagnosed or already has an existing diagnosis. You're trying to think about what might be the next best steps for them. And there could be a number of different possibilities. And so there is some research looking at how do we try and support and learn from what's happened in the past to figure out what might work well for a particular patient in front of you, and sort of personalizing or tailoring that evidence. So this is an example of one designed around deciding what medications or dosing of medications to prescribe. So you can imagine as a physician, you would input a diagnosis into your EMR. And then on the back end, the AI would look at, okay, what are all the characteristics we know about this particular patient, including that key diagnosis, and figure out what are the sort of most similar other patients. So it could be in terms of diagnosis, but also other types of characteristics, and what medications were prescribed for them. And then it also can look at, okay, on a larger view, you know, let's look at everyone who has this diagnosis and what's the frequency of the different medications. And it sort of compares these two things to come up with a ranking of what may be the best medication to do. And the important point here is that it's not telling you a single medication. This example is giving you a list with sort of this extra information, so you can use that to further inform the decision. Next. So this next category of information extraction is going back to the idea of big data, and we have all this data being generated. And we might be able to learn useful things actually more at a population level about what's going on there. So for example, you can imagine you have all this structured and unstructured data in an EHR database. And you can develop an AI algorithm that's going to search for cases, for example here, FH, and determine where they are and sort of ping them. And the output here, instead of thinking about an individual patient, it can give an overall prevalence estimate. This can help to better understand what is actually the makeup of your clinical profile or a particular population being done here. So both clinical and research implications for these types of studies. Next. Okay, and then the last example here is prediction. So now we're thinking again about figuring out, okay, I don't want to know what to do at this exact moment, but what might happen to someone in the future. So you can imagine the sort of research vision for this particular paper was, okay, you have a patient who comes in, and that's sort of flagged. And then in the background, you would have an algorithm implemented that would estimate their risk or the probability of developing hypertension in the future. And you maybe would have an option to put a setting on your EMR that says, if this risk, for example, was over 90% or whatever you could decide, then you would get an alert. And if the risk was estimated to be less than that amount, then there would be no alert. So regardless of what the patient comes in for, you can kind of dictate at what point you want to know about these risks or not. Next. So that's a number of examples, but these same sort of overall ideas of what to use AI for have been done for a lot of different types of health conditions. So about 30% of we found are for in general, and what that means is that the AI was not developed to work only with like one particular type of health condition, but to work with most or any types of things you may encounter in your practice. And then of those that targeted specific things, it was primarily chronic physical conditions, more so than acute or psychiatric. And so we're going to take a pause here and do a little poll. And so I think Rose is going to launch that. Perfect. And so now, given what you know about AI, right, we've talked about some of the different types of techniques, the types of things that's being done in primary care. What do you think are the methods that are most frequently being used? And then we're going to compare the results of this poll to what we found in this review. See the responses coming in, which is fantastic.
We'll give it just one more moment, and then we'll close it.
Perfect. Okay, so it was a bit of a tight race here. So as we can see, supervised machine learning did come out on top with about 30% of people voting for that one. And then close behind is expert systems. And then we have natural language processing, about 20%, unsupervised machine learning 8%, and then 13% computer vision. So now if we go to the next slide, or I think we end the poll, we can go. And we can see, so actually very close to what is out there is supervised machine learning and expert systems are the two biggest for sure. And then a bit of natural language processing, computer vision, and other techniques, also noting that sometimes these techniques are used together. And I also want to, if we just go next, is that there was a trend that we saw, and then I think probably a lot of you have picked up on, which is that there's been a movement for more rule-centric systems. So the earliest expert systems wouldn't necessarily be trained on like things like EHR data. It could be, for example, all of clinical practice guidelines turned into if-then rules, and then using logic to kind of work through them. All the way to the other extreme of the spectrum with these very data-centric systems, which would be something like a deep neural network where just all the processing is completely data-driven, and there's sort of everything in between. And so we saw that sort of trend and that shift in the literature here, and all of these techniques are still out there along that whole spectrum. Okay, so we can go next. And I just want to note one thing also that we found when thinking about the types of AI that are being used is that it is a very hot topic right now. And so in searching the literature, we found a lot of articles that would say they're using AI or a particular AI technique. But when we actually went in to assess their methods a little bit further, we realized it's not actually AI that they're using. That's not a value judgment on the actual tasks that are being performed, right? Because you don't need AI to do something useful, but it does show that when you're reading things, you're thinking about things, it's important to try and think about what is actually happening. So for example, we had a number of articles that said they're using natural language processing. When we look a little bit further, it's very similar to what happens if you have a Word document and you go Control F or use the find function. So here I have actually the abstract for the review, and I typed primary care, and you can see all of the exact matches to primary care are highlighted, and I could get a frequency of those words. And that could be useful, right? But that's not necessarily an intelligent process, right? If I misspelled primary, then I would miss some instances. Whereas on the right is where we actually took a lot of the abstracts we had found, and we used natural language processing techniques to say, can you give me a summary from the data? What are the main topics that are here, right? And you can see some of the trends that came out: mental health, prediction, skin cancer. And so you can kind of sense that that's a much more complex or intelligent type of task there. So that's just something to be mindful of. And we'll head to the next slide now. Okay. So that was it for sort of the academic literature. And now we had a student working with us, Raveen, doing her public health practicum project. And she was helping us to say, okay, what's actually out there though in terms of like searching websites and companies, and what's kind of happening more on the industry world in terms of what might actually be being marketed right now. And so I do just want to note, I'm going to go through some examples. I'm in no way endorsing any of these products. I haven't necessarily vetted them for quality. I'm just trying to give a sense of sort of the types of things that are out there. Okay, go to the next slide and jump into that. So we found overall 93 tools. This was run this past summer. And of them, about 70% were to assist providers. So things like assessing risk and diagnosis. And then if we move on to looking at patients, about 25% were intended for them. And of that, 10 of those tools were for remote screening or triage. So these are tools that are telling patients, you know, use this to decide whether or not you should try and book an appointment with your primary care physician, for example. And then a few of them also looking at interactions between primary care and specialist care. So we can move on to some examples. And next and also there were 36 active patents. These are things that are not out there yet, but people have said, okay, we're developing this, we want the rights to it, and just again shows this is a very active area. It's a lot of development. Okay. So thinking back to, you know, this idea of computer vision and predictions and that, one of the tools is ISA. And so it's an app for your phone. You can take a picture of a skin condition, right? And it may ask some additional questions. And at the end, it's going to come up with some sort of recommendations or further information about that skin photograph. So that would be something targeted at providers. Patients could potentially also use it on their own as well. Next. So this one here is being marketed towards patients who are interested in sort of tracking their own health and wellness. It actually uses video recognition and facial recognition to try and get someone's vital signs. So basically you look at your camera and then it's going to give sort of these estimates of like heart rate, oxygen saturation, et cetera, et cetera. And so someone could download that and be tracking that on their own. And then the third example is intended for, again, that kind of interaction. And so so it's an app to help manage referrals between primary care and specialist care. And then additionally, they have AI running in the background that's helping, for example, to predict no-shows for appointments, for also to give sort of preliminary diagnoses, again, trying to work at that sort of interaction place. And again, there are many more examples, but that's just kind of giving you an idea of the types of things. A lot of it is targeted to have something where you would have as an extra tool when you're sort of uncertain or someone's uncertain about what's going on to get some extra information. So I'm going to pass it back over to Andrew here to talk about some additional things to consider.
So there are a lot of reasons why primary care should be involved as these applications emerge. I'm sure many of you hearing about some of these tools that Jaky talked about were immediately thinking about questions or concerns also that you may have about them. There have been many concerns raised about AI in general. These are just a selection of recent books that I'd encourage you to take a look at in terms of questioning this new technology as it is starting to penetrate many different parts of our life. And we actually, webinar 6 of this series is going to be devoted to ethics and ethical concerns and mitigation of those concerns as AI starts to be applied in primary care. Just to highlight a few of them, one that is common in machine learning is bias, is essentially the issue that the data that's used to train models is often replicating biases that are prevalent in the data and in society more broadly. And this is just one example from a few years ago that an investigative journalist organization, ProPublica, looked at software that had been widely used in the US to help with sentencing suggestions, and that it was finding systemic racism towards Black individuals in terms of the length of sentence and the prediction around repeat offending. One of the underlying issues, there's the fact that the data may not be biased, but there's also something more fundamental about who is involved, who's around the table. This is a quote from an AI scientist in the US who's been very prominent in drawing attention to the lack of diversity amongst big tech companies, and also then what this leads to in terms of the types of data that are being fed into the models. So it's important to know it's not only about data. It can't just be fixed with just having more data that's representative. It's also something about who is involved with developing. And that's another point of why primary care should be involved with these discussions. Another example, just recently, this was published just a few days ago, is how algorithms are being used often in ways that are not always visible to help with things like everything from credit scores to who is approved for a loan to many different parts of social benefits, many different parts of our lives, and how one of the issues is that we may not be aware of algorithms and how it's so important to shed light on the use of them and also what the results are, and also to be able to draw questions about the algorithms. Are they being fair? Is the data that's being put in even accurate as well? And another, just even more recent, this is just from a few days ago. Last week, Google fired a very prominent scientist who's devoted to AI and ethics, and it's led to a big discussion about individuals who are within companies who draw questions. What is their rights, and are they able to raise concerns as well? And so one of the things that we have done is just to shift to what should be priorities for primary cares. With Tara Upshaw, who's one of the graduate students in the Upstream Lab, her main project was focused on really engaging in a national deliberative dialogue around what should be priorities for patients and providers. And these were some of the themes that emerged from that work. The importance of high impact applications, really thinking about training, thinking about issues like consent, addressing barriers to adoption, and also strategies to help promote adoption, particularly in areas where they are still moving to EMRs and there's still a lot of paper-based practices. What was really good to see was some key values that I think are very central to Canadian primary care came out, including equity, patient-centeredness, and patient safety. So we have one last poll that we wanted to launch, which is to get your thoughts on what would be, over the next 10 years, what do you think the priority for AI application should be? And then we'll share what we saw. So let me post the results. What you can see is that a lot of people thought that AI is going to, over the next 10 years, be used for things like proactive care, and to some extent documentation and maybe clinical decision support, and a few things like pre-visit tasks. So some of the priorities that we found were that, in fact, one of the top priorities was addressing tasks that don't really usually use the patient-physician contact, but could be actually addressed, like charting and prescription scheduling and managing referrals. Another key priority was just allocating time to its best use, and particularly administrative staff looking to see, are the tasks that they're doing right now that could be automated, allowing them to spend more time with patients and actually helping explain things. Expert systems that combine EMR data or electronic medical record data and the latest evidence was another one, addressing infrastructure, and then also just the importance of training as well. So I'm going to end actually our presentation on just trying to paint kind of a bit of a prediction, a bit of a vision, and all, of course, the caveat that, of course, no one can predict the future. But just I'm going to lay out some scenarios of what we think maybe over the next 5, 10, and 20 years things are going to look like. So I think 5 years from now, we're going to be having a lot of discussions with patients about data, privacy, and the use of algorithms. We're going to be getting comfortable with data that's generated from wearables that gets integrated into electronic records. There'll be some early tools around diagnosis and helping prioritize patients, and offices will increasingly use chatbots or other automated systems that are powered by machine learning to help with triage and answer basic questions. I think also there'll be rising concerns about the digital divide, the divide between people who have access to wearables and new technology and those who don't and are not benefiting from this. 10 years from now, I think we're going to see well-developed tools for auto charting. I think we all dream of this day when we're going to not have to do so much time spent on typing and charting. And also forms, wouldn't that be amazing, that a day where forms actually are auto-completed based on data that's in the chart, and it helps make that much more a rapid process. I think maybe a concerning thing is we may see fewer front-facing staff due to automation. This is people who work in administration for health clinics are really being seen as a job that could be automated over the next decade. So how will this change our practices? I think we'll see more AI tools operating in the background to assist with data flow and tailoring data in a way that is the best for both the provider and patient. So instead of seeing an EMR that looks the same for every patient, it's actually tailored to that patient in front of you. I think we'll see a lot more use of it in diagnosis and treatment planning, but we'll see this changing role of specialists and consultants. I think we'll see much more a breaking of the model of referring someone out to a specialist, getting a report, and then they come back. I think we'll see much more breaking down of the boundaries. And then 20 years from now, and again, this is very hard to predict what the future will look like, that maybe we'll see where a lot of the patient history and parts of the physical are actually taken by an AI assistant, and there'll be much more ongoing monitoring. That health providers will be spending a lot more time explaining the outputs and communicating and providing counseling and support, things that a machine or a program couldn't do. There'll be ongoing role of modifying these models, keeping the human in the loop and making sense of the prediction. I think health organizations will really have data scientists that are part of them that manage these resources and also are working to connect data, not only within the health system, but also to things like environmental data and community data. And I think we'll have patients that are growing acceptance of taking direction from systems and automation. It'll become much more a norm. I think there'll be ongoing struggles around the power of data companies and privacy, and concerns around surveillance and stigma will continue. So we'll end this session just by talking a little bit about what we're hoping to do. One is, we're really hoping these webinars will kickstart something we're calling the deep network, or big data to enhance and evolve primary care. We see this as a national community of practice to support the development and evaluation of AI interventions, to help with education, things like this webinar series, but also more specific training to graduate students and residents and others who are interested in being part of this. we also want to help link developers and computer scientists to providers and patients. And finally, I see this network as really helping coordinate policy advocacy, including around policy and legislation around access to data, regulating interventions, and identifying and mitigating the digital divide.